Good evening, everyone, and welcome to IF Oxford, the Science and Ideas Festival. It's time for me to introduce Oliver Evans from the National Institute for Health Research. He's going to tell you a little bit about the organisation and what it does before handing over to tonight's two speakers. So over to you, Oliver.
So good evening and welcome to our talk, which is called How to Imitate a Pancreas. I'm Oliver Evans. I'm the Communications and Engagement Lead for the National Institute for Health Research, or the NIHR, here in Thames Valley. And the NIHR really is the government's research funding arm, effectively. It spends about £1 billion a year on all types of research. That's from laboratory-based science to studies taking place in NHS hospitals. And the goal really is to improve the NHS, public health and also social care through research. And you might have heard the NIHR mentioned, in fact, in a lot of the current pandemic research. We've really been at the forefront of the research response to the COVID-19 pandemic. So I'm delighted to be joined by Professor Catherine Owen. She's a consultant in diabetes at the Churchill Hospital here in Oxford, and also Dr. Rachel Besser, who is a consultant in paediatric diabetes at the John Radcliffe Hospital here in Oxford, who has herself had diabetes for 35 years. And together they're one of the many researchers that work at something called the Oxford Centre for Diabetes, Endocrinology and Metabolism. And that's a research centre here at the Churchill Hospital. And that's a partnership between the University of Oxford and the Oxford Hospitals Trust. So I'll hand over to Catherine and Rachel.
Hello, it's great to be here. And we've got about half an hour or so now where we're going to talk to you about how we might be able to imitate a pancreas, and to talk about the clinical aspects of our job and also some of the research that's going on in this area.
So, hello everybody. Let's start off with a question. What does the pancreas do?
Well, I think we might actually start off with, where is the pancreas? And we've got our colleague here, Andy, who's going to help us demonstrate exactly where the pancreas is. Now, nothing's going to hurt, but I do have to remove his organs to do it. So there's his small intestine. I've got a feeling everything's going to fall out. There's his liver. And then if we just get behind here, this is actually where his pancreas is. It's right in the back of his tummy there. And if I hold that up, you can, I knew that was going to happen. So you can see that the pancreas is kind of quite a floppy, white organ that sits in the back of your tummy. So it doesn't look like very much, but
thank you very much. I'll hold on to the pancreas.
You look after that. And now we're going to start sharing our slides so we can talk a little bit more about the pancreas. Hang on a second. So what I hope is everyone can see that slide. And I've got another pancreas here. It's a sort of cuddly pancreas. But if we have a look inside the pancreas, we can see that the pancreas, if you look at it under a microscope, is divided up into some small bundles of cells which are called islets. And inside these islets are the beta cells, which are the things that produce the hormone insulin, which is really important hormone with regard to diabetes. So what does the pancreas do? So when we eat, the glucose levels rise in the bloodstream. That rise in glucose is detected in the pancreas, and then the beta cells respond by producing insulin. And what's insulin? Well, insulin is needed for our body cells to take up the glucose and the calories that we eat and use them as energy. So it is what gets all the energy from the food into our body, and we can't do that without insulin. So what does the pancreas normally do? So if we have a look here, this green band here shows what a normal blood glucose level is. And it normally runs in between 4 and 8 millimoles per litre, which is very tightly regulated. And you can see that after we eat breakfast, it goes up a little bit. And after we eat lunch, it goes up a little bit. And after we eat evening meal, it goes up a little bit. And the pancreas is working very hard in the background to keep that glucose level normal. So normally we have a little bit of background insulin that's trickling in all the time. But when we eat something, the pancreas responds very quickly to produce a big surge of insulin to bring the blood glucose back down, and it does it after lunch and after evening meal again. So, Rachel, what goes wrong in type 1 diabetes?
So what goes wrong in type 1 diabetes is the immune system or defense system of the body actually attacks someone's pancreas. The immune system is actually normal in people with type 1 diabetes, but for some reason, the immune system attacks those insulin producing cells in the pancreas. So the pancreas can't produce enough insulin to control the blood sugar levels. So here we can see what happens when the pancreas doesn't work. The first graph shows when someone doesn't have diabetes, and you can see the sugar levels are very tightly controlled between 4 and about 7.8. And the pancreas is actually very, very complicated. There are lots of things that raise blood sugar in the body, but only one thing that can bring it down, and that's insulin. And the pancreas does a great job at keeping it steady. So if you don't make insulin, the sugar levels can be very up and down. And the difference in this trace compared to the top trace is the variability. You can see it's going low and going high, and that's what makes having diabetes hard work. So insulin, in fact, is a very old drug and is very safe, but one of the side effects of insulin is if you give too much, you can go low or hypo, and if you don't give enough, you can be high, and that doesn't feel good either. So this really sums up here what it feels like to have a low blood sugar if you give too much insulin for the amount of food that you eat. And this was drawn by one of my patients, Phoebe, age 12, and here you can see what it feels like to her to have a low blood sugar. She says she's hot and sweaty and tired. She's confused, angry and sad. She feels wobbly, and she's got butterflies in her tummy. And diabetes can really, particularly for childhood and in adults, interfere with daily life.
So if we want to mimic a pancreas, we've already said it's a really complicated thing to do. So we've got to have a way of detecting the glucose level in the blood. And then we've got to make a decision which isn't just about what your glucose is, it's about what you're going to eat, what sports you might be wanting to do, how stressful your day is, are you giving a talk at the Oxford Science Festival, are you sick? So you've got to make a decision based on all those pieces of information and then be able to take insulin. So we thought we'd break down all those things that we have to do if we want to imitate a pancreas. So first of all, how can we detect glucose? Well, actually, detecting glucose has been something that doctors have been doing for thousands of years. Do you know in Egyptian times, doctors used to taste the urine to see if a person had diabetes? That's pretty gross. I'm glad I'm a doctor now, not in Egyptian times. But when people first started treating type 1 diabetes back in the 1920s, people used to have a chemistry lab in their house. They used to have to put 8 drops of urine in a test tube with some of this Benedict solution and see what colour it went. Later on, they made it easier to detect it in the urine by using dipsticks. But even then, urine's not actually a very good way of knowing what your glucose is doing right now, because it only reflects how much glucose has overflowed into the urine since you last went for a wee. So testing blood glucose was something that was going to help people manage their type 1 diabetes. So in the 60s, we had these massive blood glucose testing machines based in hospital clinics. But it wasn't until later on in the 80s that home blood glucose monitoring became available to people with diabetes. And we've actually got a glucose monitor here that's as big as a brick. And that's what people used to use in the 80s, whereas now we've got little blood glucose monitors. And over time, the range of blood glucose monitors has expanded and improved so that they're quicker, they take less blood, they take up less room in your handbag. So, however,
so here's an example of a blood glucose meter. And the thing with blood sugar or glucose monitoring is it's really good, but it only gives you a value at that point in time. And as Patrick, age 4, shows us here, actually, you know, it can be painful, particularly on young, soft fingers. So it would be better if there were easier ways to measure the sugar level. And in fact, there are. Some of you may have heard of the Libra or the Dexcom. These are non-invasive continuous glucose monitoring techniques. So I'll explain what this is. So here, can you see a transmitter in a little microfilament that goes under the skin into the fat below? And what it measures is the sugar level or glucose level in the interstitial fluid. And this is the fluid that bathes the red blood cell. So essentially, it is almost equivalent to the blood sugar level. And what it can do is give you, if you wear a little transmitter and a sensor, it can give you a readout. This is a 24-hour clock. This is one person's reading. And can you see it's picking up the sugar level every few minutes and it's forming a graph. So that gives a lot of information without having to do finger pricks.
So the commonest form of continuous glucose monitoring in the UK is called Freestyle Libre, and it's now used by up to 25% of people with type 1 diabetes. So it's very common. And you may have seen people in the shops or in the street wearing them. And you may also have seen some famous people wearing them. And we've actually looked at how successful this is in helping people with type 1 diabetes. We've collected data from over 9,000 people in the UK who were using Freestyle Libre. And what we found was that if they used Freestyle Libre for somewhere between 4 and 10 months, their blood sugar levels on average dropped. So here we're measuring something called HbA1c, which is a marker we use for how normal blood sugar is. So we give people a target for their HbA1c, which is hopefully close to a normal blood level. And the Freestyle Libre has helped people get a lower HbA1c, which is beneficial for their long-term health. The same study also showed that people with Freestyle Libre had less low blood sugar, so the hypos that Rachel was talking about, and they even had less hospital admissions, which is an amazing cost saving for the NHS. And they also had improved mental health and quality of life. So it's been a very successful introduction of the Freestyle Libre over the past few years.
Can I add something, Catherine? Just because, in case people don't know, the way that Libre works and that you might have seen on Theresa May is a handheld device which is held in the hand. You have to tap it against the transmitter and then that transforms the data into the graph.
Okay, thank you. So we've got very sophisticated ways of detecting glucose. How about the difficult thing about making a decision? So as I said before, people with diabetes have got to add up a whole load of different things that are going on to go from what their glucose level is to actually giving the right dose of insulin. And one of the ways we can help people with this is to offer them an education programme. And here in Oxford and in a lot of other places across the UK, we offer something called a DAPHNE course, which stands for Dose Adjustment for Normal Eating. And here's Alison, one of our dietitians at the DAPHNE course. And here are Amanda and one of our patients playing the glucose game. So you can see it's a kind of fun thing to attend. And what we do is we get people to make very detailed diaries of their blood glucose, of their insulin dose, and of how much they're eating, and in particular how much carbohydrate or starchy food they're eating. And in a week-long course, that helps people with that decision-making process. And we've done research on the effectiveness of that as well. And so this graph here shows time going out from when you did a DAPHNE course for a whole 7 years. So it's a very long time period for a research study. And you can see that if you did a DAPHNE course, this is your average HbA1c line. Whereas if you didn't do it, it's running quite a bit higher. And that's maintained over a long-term period. So a DAPHNE course is effective in helping people make a decision about what to do with their diabetes. So the final bit of the equation is insulin. Now, one of the reasons which made us think about doing this talk was because it's now 100 years or 100 years next year since insulin was first isolated, and just in 1922 it was first used as a treatment. So before that, we reflect on the fact that there wasn't really any effective treatment for type 1 diabetes. So it's been an amazing 100 years, really, hasn't it? And so this was discovered by Banting and Best, and working with John McLeod and James Collip. And it's really it was an extremely successful period of research translating into clinical practice, because between 1921 and 1922, insulin was developed as a treatment. By 1923, it was a very widespread treatment. It was being manufactured by drug companies and made widely available to people. And in 1923, and exactly on this day in 1923, Banting and MacLeod won the Nobel Prize.
Today?
It was actually today.
Wow.
Yes, I saw someone tweet about that.
Amazing.
So yes, insulin was isolated and first used in humans, but it was still a complicated thing to develop it into the treatment that we've got today. Because as you remember, insulin's got to be able to mimic the exact profile of the natural insulin in the body. So it's got to have a bit of background trickling in, and then you've got to be able to give a fast-acting component. And all that's got to be injected into the skin, because you can't take an insulin pill. So over the last 100 years, we've had developments of animal insulins and refining the formulation and the duration of activity of the insulins. And then in the early 80s, the first human insulin with the same structure as human insulin was manufactured in the lab. And then we had the first designer insulins, which mimic the body more accurately by either being faster or very long acting. And then we've got ultra long and ultra fast ones at the moment. And we've also had different ways of injecting insulin. And so we're probably going to stop sharing the slides now and show some of these bits of equipment that we've got. So hopefully.
Now, Catherine, you have got some gory bits of equipment there. Why don't you tell us what they are?
So we've got a diabetes museum in the Ocdem, and I don't know if you can see how long and sharp that needle is. It might not be projecting very well, but this is called the Palmer injector, and it was invented in the 1950s by a Scottish farmer, so he was obviously very stoic. But can you imagine the length of that needle for injecting? People also, in those days, they didn't have disposable syringes. They had to use a glass syringe, which they could then boil and sterilize for reuse with a long metal needle, again, that they used to reuse.
And then when I was diagnosed in the 1980s, this was what I used to use. And when I show the children in my clinic, they think I'm a real old person. So we used to have a mixture of cloud and clear insulin, and I'd have to draw it up twice a day with this syringe, exactly like that. And it was mixed insulin, so it was kind of medium acting and long acting. So I draw it up from the syringe and then whack it in. And actually, as Catherine, you said, the insulins actually, they didn't mimic normal human insulin. So you were constantly eating, trying to avoid hypos, jam sandwiches in the middle of the night.
Sounds good.
And then came along more modified insulin, and we had the Novo pen. So we had better long-acting insulins that didn't make you go low in the night, and fast-acting insulins. So you draw it up, put a needle on, and whack it in. Now, I'm not a competitive person, but I do want to bring out my pancreas, because what I want to remind everyone is that if you don't have diabetes, the insulin, this is the pancreas, so the insulin actually goes straight into the bloodstream. But when you have any of these devices, syringes, or whatever, a Novo pen, you're putting it into the skin, under the skin, into the fat. And that's why it takes so long to work. Do you want to see some of my old-fashioned bits of kit? Well, this, in fact, was one of the first blood glucose machines that I used. And actually, I don't use one of these anymore because I've got a sensor, which I showed you. But it's actually the size of a brick. We saw the picture. And what you do is you turn it on. It was made by Ames. Open that. You'd prick your finger, and 3 minutes later, yes, 3 minutes, Dylan, if you're listening in the audience, it would take to get a blood sugar reading. And this is my first blood glucose finger pricker, and we used to call it was nicknamed the guillotine, because what you do is you lift that up and you'd put a needle in the end, and I don't know if you can see there's a hole at the bottom, so you'd put your finger under the hole and the needle would come down, ow, and then you put the finger on a strip. But we don't have things like that anymore. It's very easy to do a finger prick. So, away with the gory stuff, should we come back to talking about technology?
Yes, so what we're going to talk about now is what came next after insulin injections. And I'm just going to share the screen again, if I can.
So then came the advent of the insulin pump. So what this is fast-acting insulin in a large syringe driver, basically in a little box, goes through a plastic tubing into a plastic straw that goes under the skin that patients insert themselves, and you change that every 3 days. So it sits, trickles in, and then every time you eat, you press a button, you calculate the carbohydrates, and it boosts it in. And this is the kind of pump that we have available to people these days. But let's look back and see, oh, if I can. Yes, let's look back to see how we got to this fantastic place. Well, in 1963, look at the insulin backpack. It was actually very effective. I'm not old enough. It's actually way before I was born, before you ask. I did not try it. And you. And it's absolutely enormous. Apparently it was effective, but you can see how impractical it would have been to carry around. And then in 1976 was the first wearable insulin pump. I don't know if you can see here along the side, if you can see the arrow. So this is a syringe driver of insulin, and it's going under the skin into this person's fat. It's actually still quite bulky. And then this is in fact, was one of the first tubed insulin pumps, Medtronic. I was lucky enough to be one of the first insulin pumpers in 2000 when I qualified as a doctor. Otherwise, I'm not quite sure how I would have done it. And now we've even got tubeless pumps where actually the insulin reservoir is held there, and you use this handheld device to give a slug of insulin. So that's fantastic. However, you still have a pump and you still have to monitor the sugar level, and you have to communicate between the two and use your brain. So you essentially have to think like a pancreas. So how can we work towards an artificial pancreas? Well, actually, it's adding a computer algorithm. So essentially what you have is an insulin pump here, and you have a sensor, and they have to communicate to each other. And up until recently, we had to do all that and try and think like a pancreas. So in developing a completely automated artificial pancreas, which should mimic the normal pancreas, so it increases insulin as the blood sugars are rising, it switches off insulin when the blood sugars are falling to stop low blood sugars, keeps it in target, there were certain steps that had to happen. So the first was the development of a sensor augmented pump. And here we've got a sensor, and here we've got an insulin pump. And I'll just talk you through this graph. So this is the sugar level going from 2 to 6, and this is the cutoff of 3 point something as being low or hypo. And what this shows is the sugar level dropping into the blue and going low without, if you didn't have a sensor augmented pump. But with a sensor augmented pump, the sensor detects when in 20 minutes time, the blood sugar is going to be hypo, and it switches off insulin delivery.
Wow.
So you completely avoid hypos, which is fantastic. But what it doesn't do, what that pump didn't do, was increase the insulin if the blood sugars were rising. And one of the things I wanted to share today was one of the closed loop systems that we've been trialing in Oxford. Is called CAMAPSFX, which doesn't roll off the tongue. And it's developed by Roman Havorka in Cambridge. Cambridge are the sponsor, and we're very lucky to be trialing it here in Oxford. And NIHR have also sponsored it, and the BRC, so that's fantastic. And I want to just break this down. So here we've got an insulin pump. Here we've got something called a Dexcom G6 sensor. And here we've got a mobile phone. So the person wears the insulin pump, insulin delivers in. At the same time, the sugar levels are detected in the interstitial fluid, and an algorithm is held on the mobile phone, and it then communicates with the insulin pump to try and keep the blood sugar levels in target as much as possible. And this is data published in the Lancet in 2018, which really shows that using having closed loop technology really helps to keep the blood glucose levels in target. So the blue is without a closed loop, so some people just wearing insulin pump, these are children and adults. And then the red is using a closed loop. So you can see that particularly overnight, the blood sugars are much more in target, and that's because most people don't eat in their sleep. But even in the day when people are eating, the blood sugars are lower than without the closed loop technology.
Wow.
Whoop. Now, I want to just, let me just go back.
Okay.
I want to introduce you to Dylan, and shout out to Dylan and his mum Kerry, who is sitting having a cup of tea, hopefully. And thanks to them for sending the pictures and letting us share Dylan's data. Dylan is in a study called the CLOUD study, which is the first worldwide study to test this technology in children with new onset type 1 diabetes. And here you can see this lovely photo of him powered by insulin. So this is one of his graphs. So I'll just explain what it shows. It shows how the closed loop is working. In the top bar, what you can see is the sugar levels being detected from the sensor throughout the 24-hour period. The little green box is when Dylan has eaten some food and he's told the pump through his mobile phone that he's going to eat something. And you can see that it does a great job at keeping the sugar levels pretty much in target. On the bottom, what you can see is how the sugar levels manage to stay pretty stable. So overnight, Dylan's not eating. And can you see the little blue lines going up and down, up and down? That's the closed loop delivering insulin. And then when Dylan eats, the algorithm communicates with the pump to give, here we go, 2.6 units of insulin for breakfast. On another day, you know, school can be very busy. What happens if you forget to give some insulin, if your mind's distracted? It happens a lot with everyone with type 1 diabetes. So this is a good example. Here you can see the blood sugar levels very tightly regulated overnight with the closed loop giving insulin when it needs to, switching off when it doesn't to avoid low blood sugar levels, and a bolus of insulin given after breakfast. And then here, I expect this is when food was eaten. And can you see here in the bottom graph that the pump switches on to give insulin to bring the blood sugar levels down to target, and then probably an afternoon snack is eaten and it does the same thing. And if you just had an insulin pump or an injection, certainly that the blood sugars would just keep on rising. If you had an insulin pump, you're wearing background insulin and you forgot to bolus. So this really provides the opportunity to allow children and adults with type 1 diabetes to keep their blood glucose levels much more in target, to minimize the chances of having low and high blood sugar levels. So I asked Dylan if he would tell me something of his experiences, and it was interesting because his mum Kerry also has type 1 diabetes and has had diabetes obviously for much longer than Dylan, so she was able to think back and think what life was like for her. And this is what Dylan said. He said, I can see mum get self-conscious if we're out to eat and she has to inject her bolus, whereas I can just do mine on my phone, and Kerry takes injections. He also says, about having the artificial pancreas, I'm glad I've been able to continue with football. It's the only thing that keeps me off YouTube, smiley face emoji, and that I can manage my diabetes easier at school. And this is what Kerry says about Dylan's diabetes.
Knowing that when Dylan's blood sugars are high, the system will give him more insulin, or when low, especially through the night, the insulin will stop, is amazing and helps us all get a good night's rest.
Then we went on to ask Kerry, you know, what life is like for her using injections.
So the daily finger pricks and injections for me can be a chore and sometimes painful. And I don't know what my bloods are between the finger pricks. So we've talked a little bit about the research that's going on with artificial pancreas and what we've been lucky to be able to use here in Oxford. But what we didn't really mention was that it took years and years and years to develop artificial pancreas technology that we could use in the clinic. But we've had continuous glucose monitors and insulin pumps for a lot longer than that. And actually, a lot of people with diabetes got a bit fed up of the medical profession getting on with inventing the artificial pancreas, because we had to go through a lot of regulation before we could have these this equipment in the clinic. So some quite smart people with type 1 diabetes, who were sort of programmers and other, computer nerds, actually sat down and wrote their own.
And bankers.
Bankers, yeah, they needed money too. They sat down and wrote their own computer algorithms to link their own CGMs to their pumps, and that was called the "We Are Not Waiting" movement, in the sense that we're not waiting for you guys to get your asses in gear and give us an artificial pancreas. And this has been hugely successful. I mean, and their software is all open. It's all called Open APS, Open Artificial Pancreas. So it's available for people with diabetes who haven't yet been able to access this kind of technology through traditional medical routes. And they provide peer support and help with running these systems. And it's one of the big advantages of, particularly for parents of children with diabetes, was if you imagine you've got a young child with diabetes and you don't know if their blood sugar is going to go low in the night, you can imagine there would be a lot of anxiety around that. So people were able to monitor their children's blood sugars through a mobile phone or the internet without having to keep going into their room 4 or 5 times in the night to check that they were okay and not having a hypo.
And also, I think at work they could just get the blood sugars up on the screen on their laptop.
See what was happening at school, exactly. Yeah. So within our clinic, there are a number of people who are running Open APS, and we help them as much as we can. Although they don't need much help from us.
No more than us.
So finally, we've talked about research, we've talked about do it yourself, and really over the last year or so, these closed loop systems are now coming finally to the diabetes clinic, and we've got 3 commercial systems available. And what I've projected here just shows the sort of data we can get in our clinic when we see a patient with type 1 diabetes who's running a closed loop system. So again, on the top graph, we've got the CGM trace, and here this is very, very busy. Look how much information there is. The grey line, the patient's told me when he's asleep. The yellow line, patient's told me when he's doing some activity. Again, this blue wiggly line is the background insulin, which varies according to what the blood glucose is doing. So we can see it's higher here when the glucose is a bit high just after bedtime. The solid blue bars are when the person's told the pump that they're having a meal, so it gives a bolus, a chunk of insulin to deal with that. And this red line here is when the pump is switching itself off because the blood sugar's low. So here you see the blood sugar drop down, pump switches off, blood sugar drops down, pump switches off. And we've also got one example of when the pump here, this little one in the tiny one, in the little box, a 0.4, the pump's actually deciding for itself to give a bolus because the blood's rising. So we've got a huge amount of information there.
And it's interesting. So this is the T-Slim, isn't it?
Yes.
Yeah, for anyone wondering. So the other one I showed, the CAMAPSFX, does all that, but you don't see it in this way. Yeah. But it's nice to see it in colour.
Okay. So we want to think about some of the pros and cons of technology.
Yeah, because technology, so we offer pumps to about 50% of our 350 children in the Oxford Clinic, and about, well, I hope I don't get this figure wrong, 20 to 25% have some kind of sensing, whether it's a Libre or the next version of Dexcom. But actually technology isn't for everyone, and people can manage very well without it, but it can be more hard work. So what are the advantages and disadvantages of technology? Well, the advantages are that you can kind of function more like a pancreas if you want to do that, and the tighter blood sugars is associated with improved health outcomes. You're going to have less low blood sugars, whether you just use some kind of sensor or a pump alone altogether, and there's less variability, so less swinging. And many people who obviously carry on using it feel it improves their quality of life. But the disadvantages are you have to wear it 24 hours a day, and like any technology, it can fail, and so you have to have a backup plan. It is costly, and that's why it can't be funded on the NHS for everyone at the moment. And in fact, having access to all the information can cause quite a lot of worry. Sometimes it's quite nice to turn it off and not see the wiggly lines. And there are alarms, and there is such a thing as alarm fatigue.
You just get fed up of them going off.
Just get so fed up of them going off, and some people switch them off completely, and then of course you can't take action. So it's a balance.
Okay, so drawing to a close now, thinking about the future, we're amazingly lucky that the artificial pancreas is now available. But we quite strongly believe that diabetes technology should be for anyone who can benefit from it. And at the moment, the cost is still limiting the widespread use. So.
And the other thing to say, and disclaimer, this is not the views of the organisations where we work, but you know, if technology is okay for our former Prime Minister, it should be okay and available for everyone with type 1 diabetes and other forms of diabetes if they need it.
Absolutely. So we'll just draw to a close. I hope that was a bit of a fast run through of 100 years of diabetes technology, but thanks for listening.
I enjoyed that.
And we'll be happy to take some questions now.
Thanks a lot, Catherine. That was a lot of fun and very informative. Thank you. So yeah, we've got 3 questions here. So Sophie asks, how do you get around the medico-legal issues with algorithm-controlled pumps?
Well, I think for people who are having a do-it-yourself pump, the open APS, I think we have to be quite honest with them that this is not a system that's licensed for use in the NHS, so we can't recommend it, we can't set it up, and we can't exactly tell them how to run it. But most, and every consultant and diabetes centre will be a little bit different, but most of us are sort of keen to help without saying that we absolutely authorise the use of it. For the systems that are now available on the NHS, it's not really...
It's not an issue. They've all been through rigorous randomised control trials, and any device goes through its own regulatory investigation and safeguarding. So these are technologies that have been through rigorous research.
But I mean, there are risks associated. I mean, if your pump is supposed to be dispensing insulin and your little cannula blocks up in the night, it can be risky. So that's why that we always recommend lots of safeguards, such as testing bloods regularly when you're on an insulin pump. And
really learning to become an expert of your own diabetes, because you know, you should ideally be an expert. Then you go to your doctors and nurses who have a lot of expertise and experience, and the combination should be very powerful. So one size doesn't fit all.
Thank you. I've got a couple of questions here from John, so I'll give them together. John's a Dexcom user. He says, what would happen if you lost your phone or broke it or it was stolen? And also, why can't the algorithm that's in the phone just be put in the pump? Therefore, you don't need the phone.
So I think that it's like if you lost your phone for anything, you've got to have a backup. I mean, there is a Dexcom receiver, isn't there? Do people with Dexcoms carry it around with them?
Yeah, I mean, they do if they don't, you know, have a mobile phone that's compatible with the Dexcom. But yeah, if you lose your phone, you have to go back to finger pricks.
Yeah. Yeah. What was the other question? Sorry.
Why doesn't the Dexcom? Why isn't it integrated?
I think for the tandem system, isn't it, in the actual tandem pump? Yeah. So all systems are a little bit different, and
with the Medtronic, you can see the sensor trays as well.
Yeah. So systems are a little bit different, but you don't necessarily need to have a mobile phone for all of them, and that's why we need to have the choice of it's good to have a choice. That if you don't have a very posh phone, you can still have a closed loop.
Yeah, and you know, some people will prefer to bolus from the pump, some people will prefer to bolus from a mobile phone, others will prefer to bolus from a handset. And what I've learnt more and more is those differences are really important. So patient choice is very important. If we kind of give over our strong opinions to families or to adult patients, they won't be successful as if they choose the device that suits them. So a lot of listening.
You have a comment from Dylan who says, great presentation, Rachel, would love to shout out.
Oh, thanks, Dylan.
And Mary asks, does this technology have any place in diabetes type 2?
Well, it's a really good question, because possibly it could or it should, but at the moment, there's two. I mean, I think there's two aspects. Firstly, an awful lot of people with type 2 diabetes don't use insulin. They might use insulin, but it's not so intensive. They don't carb count. They don't have the issue of complete insulin deficiency that people with type 1 diabetes have. So for that reason, these kind of technologies have largely, in the UK anyway, not been funded for people with type 2 diabetes. I mean, I think there are quite a number of people with type 2 diabetes who will self-fund sensing technology.
And we've used sensors in some of our young people with type 2 diabetes, because having that information is just, it's nothing like actually seeing what happens to your blood sugar to feel like you want to make a change or modify how you're doing things.
So I think it will probably happen over the next decade. Sounds like a long time. I mean, I think we have to get used to the idea that we're getting it for everyone with type 1 diabetes who qualifies for it, and there's still quite a lot of inequality over different parts of the country. The good and bad things about the NHS are that it's all supposed to be equal, but that means that there are cost restrictions, aren't there? So it's that conundrum.
And we're more fortunate, I think, in paediatrics. We've got more access.
Yeah.
Are there any other questions? I think there are.
Yeah, there's one here. So Simon asks, is research looking at ways to transplant islet cells? And he also picks up something that I think you mentioned in the talk, which is, do you believe it would be possible to create a tablet which can maintain and regulate insulin sufficiently instead of injections?
So at the moment, we don't have any really good way of getting insulin as a drug into the body without injecting it. There is a formulation of insulin that is inhaled, like an asthma inhaler. It's not available in the UK. When it was available, it wasn't very successful. So, and it has various problems around having insulin in your lungs, which is not the best place for insulin. There are companies which are trying to develop an insulin pill. Definitely, that would be, like the holy grail for all the pharma companies. But you can see that in 100 years, they haven't quite got there yet. But there is research going on.
And the problem is the stomach is full of acid, so that breaks down the protein, and insulin is the protein.
Yeah, that's right.
And the other question, I think, was about islet transplantation. So islet transplantation does happen. It's limited because it's difficult to get enough source to infuse islets into someone with type 1 diabetes.
It has to come from a donor, like any transplantation.
Yeah, and of course rejection can happen. So it's used at the moment only really in adults of individuals who have severe hypoglycemia.
Yeah, or for people who are having a transplant, say they need a kidney transplant, they may have a whole pancreas transplant. So there is a little bit of transplantation going on, and Oxford is a centre that does both islet and whole pancreas transplants.
But the holy grail, I suppose, will be modifying and creating a beta cell. And Paul Johnson, who's the islet transplant surgeon, I was chatting to the other day, and he was talking about this MapPlan device. So you can, the ideal would be to put a modified islet into a capsule. So these are encapsulated transplantation, and you can have some nutrients that feed up into the beta cell so it stays alive, and some oxygen, but kind of pores that allow the nutrients and oxygen to go in, but are too big to allow the immune cells which damage the beta cells to get in, because that's the problem. The immune destruction can carry on. So the only way that could work is if it's maintained,
it's protected in some way. So again, an area that's active research, but we're not quite there. Yes.
And we are actually going to start in teenagers. We do some work with Paul, but not in the situation of type 1 diabetes, in the situation of chronic pancreatitis.
Okay.
Do islet autotransplantation. So we'll build up a bit of expertise. I think you've probably got more expertise in islet transplantation in adults than we do in peds.
Yes,
I think
so, yes.
Does that answer your question, Simon?
Oliver, are there any more questions?
I don't know, Kathy, have we got time for any more questions?
Yes, I mean, we are just at the end of our allotted time, but I'm happy to run forward for a few more minutes to finish the questions.
Okay. So we have a question here that says, what do the team think is the next step of type 1 diabetes management after the closed loop?
So I think that there's going to be a number of different things that are going to happen. And one very exciting thing for people with newly diagnosed type 1 diabetes is that we're actually going to be able to offer a treatment other than insulin, an immunotherapy treatment that will hopefully slow down their type 1 diabetes process. Because most people, when they get type 1 diabetes, still have a bit of their own insulin production, which is actually really, really helpful in both helping with blood glucose levels and helping with avoiding low blood sugars. So in Oxford, we're part of the Type 1 Immunotherapy Consortium in the UK, and we're offering different immunotherapy research studies because we haven't got a treatment yet. We're doing research studies to test out different treatments, but we're hoping that we could potentially offer everyone, adult or child, with type 1 diabetes a research study of immunotherapy.
Yeah, we'd love to do that. We've got an immunotherapy trial running, ITAD, which helps in newly diagnosed children and adolescents, which works by, as Catherine says, trying to preserve the pancreatic function that's left by boosting the good immune cells, and that's a really exciting thing to be part of. But I tell you, I'm putting my money on, although, you know, I'm a big fan of immunotherapy and we have to try safe immunotherapy. I'm putting my money on technology. I want to see the pumps getting smaller. I want to see the sensors getting smarter and the algorithms getting tighter. But the big thing,
what about prevention?
Yeah, well, I was just thinking prevention. So we've just put in a big NIHR bid, actually, just waiting for the outcome on prevention, where we want to screen children to find out who for sure is going to get type 1 diabetes. We can do that by measuring their diabetes antibodies. If you've got 2 or more antibodies in the blood, you will get type 1 diabetes. The question is when. Why does it matter to pick it up? Well, first of all, we can tell families that their child's going to get type 1 diabetes so they can get used to it. They can prevent them presenting very, very sick. But also picking up on the idea of immunotherapy, there are going to be some safe immunotherapies that we can trial in children and adults who we know are going to get type 1 diabetes, but whose blood sugars are stable. So I think there's going to be something for everyone. I don't think we're going to be able to retire yet, but we want to be able to.
And there's just a couple of very quick, short questions, factual questions about the CAMAPSFX. There's a question whether it's available to adults not in the study, and also whether the data from the pump needs to be protected, and if so, how do you protect it?
Well, actually, the CAMAPSFX has just received a European stamp of approval, CE mark, which is amazing. So it is available to children and adults.
Yes, it's going to be one of the pump options that we'll be able to offer people in the very near future. So, of course, you still have to either qualify for a CGM sensor, which is
if you want to get it funded,
or if you want to get it funded on the NHS, or you have to agree to self-fund the CGM sensor, but it is available. It's one of the options that we've got now. Yes. Yeah. And how do you protect the data? Well, do you mean, I think maybe what you're asking about is whether pumps could be hacked through the internet or something like that. Don't know. I mean, we haven't had any examples of that happening. But I
mean, you are right. I think you're picking up on the fact that the data goes into the cloud. Yeah.
Well, it's still all the control is at local level, isn't it? So I think if could other people get access to your blood sugar data, it's probably not that interesting.
Well, actually, interesting and controversially, often these the companies, you know, whether it's Dexcom or Abbott or whatever, who manufacture all these amazing devices, you often need to use their platform to download the data. And if you look very carefully, if the person who asked the question has got diabetes, if you looked at the fine print, you will see that to be able to access, whether it's DiSend or whatever, you have to you sign your life away and your data will be shared. Otherwise,
in an anonymous way.
In an anonymous way.
Yeah.
And actually, I used to feel funny about that, but now I just think, you know, the more data, the better. Let's get it published. Let's understand how it's useful and when is it not useful to people with diabetes, as long as it's not linked to my bank balance.
Well, they wouldn't find much in there, would they?
Okay, you're giving my secrets away now.
Thank you very much, Rachel and Catherine. That was great. I'm just going to hand back to Kathy now. Thank you for dialing in. We really hope you found it useful. And if you're interested in taking part in diabetes research, please go to the Be Part of Research website, bepartofresearch.uk. There's plenty of information about what taking part in research involves and also studies you can take part in.
Thank you, Oliver, and a huge thank you to Catherine and Rachel for such an interesting talk this evening. I've certainly found it extremely enlightening. But all that remains is for me to thank once again our speakers and to thank all our audience for coming tonight, and we will see you at the next event very soon.